Hypertension pharmacotherapeutics. Some practice pearls for you. Hypertension is a big money thing. We treat it on so many patients. It's something that you're going to be doing. So once you get the gist of it, hopefully it will make a lot of sense to you. Major risk factor for stroke, myocardial infarction, vascular disease, and chronic kidney disease. Chronic hypertension effect on the organ systems is referred to as target organ damage. I have a schematic coming up that will make that clear for you. Basically, left ventricular hypertrophy, cardiovascular disease such as MI, arrhythmia problems, cerebrovascular disease, hypertensive retinopathy, and nephropathy, most common manifestations of end target. Primary hypertension, formerly we called this essential hypertension. Classification of blood pressure does differ between the guidelines, AHA, ACA, JNC8. The JNC8 was the one that I put in here, as well as up-to-date kind of backed up JNC8. So pathogenesis of the primary hypertension is actually poorly understood. Multiple issues, genetic, environmental factors that affect CV and renal structure function. So normal physiology is affected by multiple things. Here's a nice little schematic of all of the things that are involved in normal blood pressure management. So obviously the renin-aldosterone angiotensin system, natriuretic peptides that are in the heart, the endothelium, the sympathetic nervous system, and the immune system also play key. So all of that, in addition to some environmental factors, is likely how we get hypertension. If you remember this nice little schematic to kind of bring it all together. So BP is related to cardiac output, peripheral vascular resistance. Cardiac output is related to heart rate and stroke volume, right? And peripheral vascular resistance is related to circulating factors such as Ang2, alpha receptors, viscosity of the blood, and local regulators on the vasculature such as nitric oxide, endothelium. All of that takes into consideration to get the vascular resistance. Heart rate is what? Norepi, sympathetic nervous system, as well as parasympathetic nervous system. So increase in the sympathetic, decrease in the parasympathetic, both have effects on the heart rate. Then we have contractility. Again, sympathetic nervous system and parasympathetic nervous system is going to influence that as well, and norepi. Stroke volume, you got your peripheral vascular venous return. So what's the blood volume? What's the venous tone? This is going to be talking about preload and afterload. And then the other players, in addition to the sympathetic nervous system, the parasympathetic nervous system is ADH and aldosterone, because they're controlling your volume. All of that, thirst is thrown in there too, so increased thirst. So all of that is basically how we get our BP. So multiple players in here could be abnormal, and that's basically what that schematic is coming back and saying. You have a whole bunch of things that go on related to the blood pressure. So not necessarily one medication is going to cover all of these things. And that's why we do have multiple classes. What is also good to know is that in the pre-hypertensive as well as the established hypertensive stage, most patients are asymptomatic. This is something that you are going to find by doing good medicine and getting vital signs every 3 months, because that's when it's going to show up. Patients are asymptomatic usually until we really get into the systematic disease process. And then you can see here on the schematic, we already have evidence of target organ disease. So proteinuria, nephrosclerosis, left ventricular hypertrophy, retinopathy, and some lesions within the brain called Binswanger lesions. Symptomatic is actually pretty low on the totem pole here when you think about it. So we would then have evidence of chronic kidney disease, coronary artery disease, arrhythmias, a TIA, or some dementia signs showing up. And then end stage disease is basically these poor outcomes such as MI, heart failure, stroke, and then renal disease. And then ultimately it contributes to the patient's death. So what we have to really be good is getting these patients in here. So preventing progression as well as treating appropriately and making sure that we get that preventative medicine to delay the progression of the hypertension. Therapeutic interventions and goals. So we're not just treating hypertension, and that's what these quarterly visits are going to be taking into incorporation is obesity, hypercholesterolemia, most likely, and then smoking if that's present, and then diabetes also if that's present. These things all go together. They are as important as managing the hypertension alone. So if you don't make sure the patient is doing something about his obesity or taking care of his diabetes or his lipids, the outcomes are likely going to be the same. So you need to manage all of the cardiovascular risk factors. The way that we determine risk is called the ASCVD risk calculator. You're going to use the risk estimator because you need to know what your patient's risk is starting out at. Takes into consideration age, sex, race, blood pressure, cholesterol. Is it treated? Is it not treated? Are they taking aspirin? Are they a smoker? And do they have diabetes? Those are the main things. So the only thing that is different between what it asks you is the other calculator does not have this coronary artery calcification. The coronary artery calcification is basically based on this Agatston score, and that is something that is done for patients that are more higher risk, that you definitely want to get evidence of any intraluminal calcifications. The JNC, which stands for the Joint National Committee 8, basically has made this stated that get the pressure down. It has otherwise just basically changed definitions for control in the elderly versus the regular population. We'll get into that a little bit later. Beta blockers are no longer first-line agents, and there is an emphasis on multiple therapeutic agents at lower doses versus one agent at maximal dosing. So when we think back to what we just talked about with that little schematic of both how many mechanisms are involved in blood pressure regulation, maximizing one medication that may not be getting the job done doesn't necessarily make sense when we might be needing to put a different pathophysiological directive by another medication and target something else. So that's what they're saying by emphasizing multiple therapeutic agents at lower doses, is we're going to get multiple things, something targeting the RAS, something targeting the peripheral vascular, so that we're hitting all of the pathophysiological disturbances that are incorporated into hypertension. So here's a nice little schematic. This gives you a lot of information. Basically, the adult age greater than 18 years with hypertension, implement lifestyle interventions, continue throughout all management. This does not stop. You reinforce and re-educate every visit. Set your blood pressure goal, initiate blood pressure medication based on age, diabetes, and chronic kidney disease. So basically, you can draw a line down here. So this is chronic kidney disease. So this one changes basically your viewpoint. The rest of these are related to one, here's diabetes, or age with no diabetes and CKD. So you could draw a line there. And it's very simple. Less than 60 years old, we have more lower targets. The choice of therapy is based on ethnicity, African American versus not, and which ones are preferred. So you see the only variation between African Americans and non is that we do not utilize ACE or ARBs, all right? Preferred is calcium channel blockers and thiazide diuretics in the African American population. So then over here, the only thing that trumps all of these recommendations is if you have present proteinuria and chronic kidney disease. So likely you will have proteinuria, and we're trying to diminish this. Proteinuria means that we are starting to have some end target damage, and we need to reduce this. So we have blood pressure goals, but then we need to get a cardioprotective agent or a renal protective agent on there, such as an ACE or an ARB. Now, what's interesting down here is we talked about that JNC8. So I believe I pulled this from a 5-minute clinical consult. So what they're saying is you maximize the first drug before adding a second, or you add a second medication before reaching maximum dose of the first medication, or start with 2 medication classes separately or as fixed dose combination. So really, it's ultimately you need to understand mechanism of action, where you think your patient's pathophysiological disturbances are coming from. You may not know that until you use one of these medications and it doesn't work, okay? And then you move on to the next. So here's the breakdown of it. Lifestyle interventions across the board, and I have them coming up and they're clearly delineated for you. First line medications are 1 of 4. You can do a thiazide, an ACE, an ANG, or a calcium channel blocker. I have comorbidities that are coming up as well, and that's going to trump sometimes when you use one over another, and it'll make a little bit more sense. Other hypertensive medications include beta blockers and renin inhibitors. Those are direct renin inhibitors. Drug class recommendations based on comorbid condition. Heart failure, AFib, angina, myocardial infarction in the acute. This is right after myocardial infarction. Diabetes, chronic kidney disease, and proteinuria. There is all of those questions. This is a high yield. If you need to remember anything, boards goes after this stuff highly. They need you to understand when you're initiating a drug based on comorbid conditions. High yield. Goals of treatment by JNC8 basically said prevent the rise in the BPs with age, improve control of hypertension. BP goal is 150/90 if there's no CKD or DM and the patients are over 60. So we are liberalizing those targets. We do not want to increase the risk of falls, so we are going to allow them to ride higher. If the patient is any age with CKD or DM, then we are going to lower those because we already have potential high-risk situations and we need to make sure that blood pressure stays under control. Focus should be on systolic if the diastolic is abnormal, but we're treat to target with a systolic. Improve recognition of prehypertension, stop progression to hypertension, and reduce ethnic, socioeconomic, and regional variations of care. Here are the lifestyle modifications. This is also high yield. There is the DASH diet, so understand what is included in the DASH diet. You will have to educate on that. Here I have broken down the risk factors for you. High risk is that we already really have target organ damage or cardiovascular disease, or evidence of other target ends such as nephropathy, retinopathy, peripheral vascular disease. So let's take a look at the pharmacological management of hypertension. You know now the schematic of how you're going to choose your hypertensive medications. Now we're going to discuss classes. So first up is thiazide and thiazide-like diuretics. That includes chlorothiazide, hydrochlorothiazide, metolazone, chlorothiazide. There is actually another one called indapamide. So these are very effective in African American population, preferred initial therapy in African American people. Very easy once daily dosing, minor adverse effect profile, and relatively low cost. So very good standard therapeutic intervention. Mechanism of action is not completely understood, but it exerts its effect on the luminal surface of the tubule. It inhibits sodium and chloride reabsorption, which equals increased urine volume. It needs an adequate renal perfusion to work. So over here is your 4, which is your thiazide diuretics. You can see here it is going to work on the distal convoluted tubule, and it basically is going to block reabsorption of sodium and chloride, which will ultimately result in fluid being diuresed out. The side effects are also related to this mechanism, so it inhibits sodium and chloride resorption, but with that also comes some other metabolic complications. So we do obviously have a risk of low sodium, right? Because we are inhibiting reabsorption. The other thing that comes with this too is potassium issues, sorry. So you will actually have a risk of hypokalemia. The other thing that it will affect on the low side is MAG. Now, the other metabolic disturbances that it can create are the other way. It increases glycemia, blood glucose. It increases uric acid, which we talked about that with gout the other week. It also can increase lipids. Now, these are all dose dependent. So the higher the dose of the thiazide diuretic, the more problems you're going to have with your side effects and your metabolic disturbances. Chlorothalidone is more effective than hydrochlorothiazide at reducing risk. There was an all-hat trial and it revealed that chlorothalidone is more potent and better. But we see hydrochlorothiazide all the time. We don't really see chlorothalidone often. So these are dose dependent, meaning the higher the dose, the more problems you're going to get. Side effects that are not dose dependent are insomnia and sexual dysfunction. They are not dose dependent. What you need to know is basically BUN, creatinine, and electrolytes. Obviously, if we're potentially disturbing all of those electrolytes, you better know what they are. You better know that you need good kidney function. Renal dosing is not defined. There's no contraindications, but you need good filtration and you need good GFR, so take that into consideration. Hepatic dosing is advised with caution, And then the common reactions are those electrolyte disturbances, especially hypokalemia and hyponatremia. So be aware of that. Increased glucose and increased uric acid. Serious reactions are pancreatitis, hypokalemia, severe, and arrhythmias, obviously related to some potassium issues. The other side effects, of course, would be dry mouth, dehydration based, right? So anything with a diuretic effect, dehydration, dry mouth. There's also another one that's a little bizarre. Increase the risk of skin cancer. That is because they actually enhance the DNA damage that happens from UVB exposure. Very interesting, I think. Next up is potassium sparing diuretics. So this incorporates spirolactolone, amiloride, triamterene. So these promote sodium excretion but retain potassium in the distal tubule. So if we take a look at where this is working on this aldosterone pathway back here, and we basically will end up with retaining potassium in the distal tubule, but you're going to lose sodium. Usually we don't use these for primary diuresis, but they may be used in combination with thiazide. Your pharmacobrief, the gentleman is on most of these medications, and we're going to see how many of you got the answer to the pharmacobrief at the end of this after we go through these. It was a rough one, so that was probably, if I had to do 1 to 5, that one was a 5. Resistant hypertension may present itself quite often. These guys are really good for resistant hypertension. Spirolactolone by itself is actually indicated. So amiloride and triamterene are very important too, but spirolactolone is very important for resistant hypertension. Now, the difference is here, you can kind of draw a line because these have a little bit of action potential differences. So spirolactolone, you need to think endocrine. All right. Spirolactolone works on the mineralocorticoid side. So if you have issues in the endocrine world, spirolactolone may or may not be indicated just on the fact that it is going to have endocrine-like side effects, as well as if there's any disease concerns with spirolactolone, such as Addison's or diabetes, it may create the situation and may make it worse. Amiloride or triamterene, they do not have any effect on the mineralocorticoid receptor. They block sodium channel, but do not affect the mineralocorticoid. So you could use those if you had endocrine concerns. The side effects that come with spirolactolone are gynecomastia, menstrual irregularities in females, impotence, and decreased libido. Definitely on the endocrine reproductive spectrum. So that's what you need to be aware of with that. So these basically block aldosterone action in CHF, so very good in that situation. They block, the blockade of aldosterone has been associated with decreased end organ fibrosis. And you can see here, really good for our heart failure patient. Potassium sparing diuretics is they will decrease renal perfusion. So very high yield. You have to be very careful with ACE inhibitors as well. ACE inhibitors, electrolytes, creatinine at baseline, and then you have to monitor a lot more because of potential issues. Obviously, ACE inhibitors are going to have a potassium issue. Baseline monitoring, so electrolytes, especially concerned about potassium, BUN, and creatinine, you need to know your perfusion. You are going to monitor more frequently if you have DM, elderly, or an ill patient. Renal dosing. Caution if the BUN is greater than 30 or the creatinine is greater than 1.5. And hepatic dosing, be very careful. Avoid most cases with severe disease. Common reactions, dizziness, fatigue, headache. So your potassium, if it's spared, you are going to have a risk of hyperkalemia, dehydration. Serious reactions are aplastic anemia, hyperkalemia, neutropenia. Also be careful with the Beers list for this. It can induce SIADH. These do not work on any of the CYP 450s. Next up is ACE inhibitors and angiotensin II receptor blockers. I kind of included these on the same slide because they do work on the same pathway. You just have to understand, and I have a nice schematic coming up. So ACE inhibitors are basically angiotensin converting enzyme inhibitors and angiotensin II receptor blocker. The name says it all. If you spell it out, you know the mechanism of action. The ACE inhibitor inhibits angiotensin converting enzyme, ACE, interfering with conversion of Ang1 to Ang2. The Ang2 receptor blocker antagonizes the vasoconstrictive effects of Ang2 at the receptor sites, kidney, brain, heart, arterial walls, decreases peripheral vascular resistance. It is not as protective as ACEs when we are talking about kidney protection. So that's what you need to know. They will help, but we prefer ACEs when we're talking about proteinuria and decreasing that nephropathy risk. ACE inhibitors have two distinct side effects that really put them different than the ARBs, and that is that cough and angioedema. ARBs have more of a hypotensive effect, so just be aware of those two big differences. Otherwise, they all kind of really have the main side effects are similar. All right. Hypotension, kidney injury, hyperkalemia, pregnancy-related issues. So these guys do not get anywhere near a pregnant lady. All right. So if you have anybody that is in that age group or potential of childbearing, be very, very cautious with ACE inhibitors and Ang2 receptor blockers. What's very interesting about this cough is that females get it more than males do. It presents itself in 5 to 20% of the population. It will present itself within 1 week to 6 months of you initiating the ACE inhibitor. It will also has more of an affinity for Chinese ethnicity. It will occur with rechallenge. So if you have a cough with Prinavil, you're going to have a cough with benazepril. All right, so it doesn't go away. It's a class effect, and you have one, you're going to have it with the other. So here's the mechanism of action. So remember, angiotensinogen is activated by renin. Renin then activates it into Ang1. Angiotensin converting enzyme then activates Ang1 into Ang2. Ang2 either works down here or also goes out to the periphery. This is where we basically will draw the line. So if we're having ACE inhibitor, we're going to stop. So basically, we're going to stop Ang1 to Ang2. We will stop all of these effects then below the line. When we're talking about ARBs, we are not doing here, but what we're going to do is stop these vasodilator effects at those peripheral receptor sites. So brain, heart, kidney, and arterioles. So if you understand that, then you know pretty much how your mechanism of ACE inhibitors and ARBs work. So let's take a look at ACE inhibitor lisinopril. So this is the most popular. You can see there CHF dosing versus hypertension dosing. And you can see that it starts a little bit differently. And that's just something that you'll learn by looking things up. You're not going to necessarily memorize it other than knowing that hypertension is a higher dose. Renal dosing, creatinine clearance less than 30. Hepatic dosing has not been defined, and monitoring BUN creatinine at baseline then periodically. Renal artery stenosis is high yield. If you have a patient who's high risk or has a diagnosis of this, you have to be very careful with ACE inhibitors. So BP, white blood cell, especially if there's a collagen vascular disease, and renal impairment, because it can create some side effects. There's a black box warning on fetal toxicity, neonatal morbidity, and mortality. So here are all of those things that we talked about. So dizziness, hypotension, headache, cough, but this is an ACE. So you're going to have higher risk cough, higher risk angioedema, and less risk hypotension, but it is still prevalent. BUN creatinine will be elevated, hyperkalemia, fatigue, photosensitivity, hyperuricemia. You can see no liver metabolism. It is 100% urinary, excreted, unchanged. Half-life 12 hours, avoid use. Breastfeeding consider, and it is appropriate in beers. Just be careful with your hypotension. So when do you stop these medications? So basically potassium issues. So uncontrolled hypokalemia, severe hyperkalemia, and a serum creatinine bump that is significantly above 30%. And that usually 6 to 8 weeks. So make sure you're rechecking your labs within that time frame. Next up is calcium channel blockers. So we have two types, non-dihydropyridines and dihydropyridines. Basically, the difference is their action, where they work. They are both calcium channel blockers, but one works directly on the cardiac cells, the other works on the arterial smooth muscle. Both working on the L-type calcium channels. I have a nice little schematic here for you. So here you see calcium in the sarcoplasmic reticulum and basically related to contraction. So here we have the calcium. This is a cardiac myocyte involved with the sarcoplasmic reticulum. That is what's involved with the contractility and the heart muscle. So basically will aid in contraction of the heart muscle. When it's talking about working on the smooth muscle, then if this was a smooth muscle, then it's going to act on the smooth muscle and create dilation by contracting the smooth muscle wall. So your non-dihydropyridines are diltiazem and verapamil. They act directly on cardiac cells, so they are a less potent vasodilator, but a better heart rate controller. And we all know this because what do we do for AFib? We give cardizem. Now, the dihydropyridines, there are basically very potent dilators. Non-dihydropyridines have some relative contraindications. So if you understand mechanism of action, then you're going to know that you can't really utilize these guys with beta blockers. The other thing is heart failure with reduced EF. Be very cautious there. It's a negative inotropic and it can cause some issues with contractility. Verapamil is big with the heart failure. Be careful there. PKPD, all CCBs are metabolized by the liver. Big CYP, and it is the big one, 3A4, which we know a lot of medications work on, right? Also, what then you need to look out for is grapefruit. Adverse reaction: constipation, dizziness, headaches, edema, rash, gingival hyperplasia, AV block. Contraindications, I already talked about this. Second and third degree AV block, CHF, sick sinus syndrome. Drug interactions include increased risk. The dihydropyridines lead to headache, lightheadedness, flushing, and dose-dependent peripheral edema. So peripheral edema is big with the CCBs, all right? And then there's also this gingival hyperplasia, which could be a potential. That is associated more with the both classes. The edema is really associated with the dihydropyridines. Think of action, it's working more on your periphery. The major potential adverse of the non-dihydropyridines is constipation, in addition to heart rate issues. So that you're really getting more into bradycardia risk, worsening cardiac output, and that's related to that negative chronotropic and inotropic effects. If you want to break it apart in your brain, but basically this is what you need to know. All right, so increased risk of heart issues when used with a beta blocker, so be very careful. Increases risk of dig and carbazepine, so be careful with your these medications, and it's all related to your CYP 450s. And then it potentiates other antihypertensives. Next up is the beta blockers for the use in hypertension. So I'm not going to spend too much time here because it's only indicated if there's a clinical reason that it should be utilized, such as AFib, heart failure, angina. Otherwise, beta blockers should not be utilized to treat hypertension, and especially as monotherapy unless one of those other adverse condition is present, particularly in patients over 60 years old. Compared with any antihypertensive drugs in primary treatment, beta blockers may be associated with inferior protection against stroke and all-risk mortality. The effects are primarily seen in those greater than 60-year-olds. Beta blockers are also associated with impaired glucose tolerance and increased risk of new onset diabetes. So again, the beta blockers are going to work on the adrenergic receptors. They're going to block beta adrenergic mechanism, which would be beta receptors, which would be heart muscle contraction, smooth muscle relaxation, and glycogenolysis, as you can see over here. Next up are alpha adrenergic blockers, so prazosin, terazosin, and doxazosin. A lot of times you're going to see these on board for other indications, but you can utilize them for hypertension, especially in those resistant hypertension patients. So antagonist to the alpha receptors, so same theory that we talked about the beta blockers. So the alpha is going to be the alpha 1, which is going to lead to vasodilation. Clinical indications are hypertension, but also BPH and Raynaud's disease. Adverse effects, orthostasis, headache, drowsiness, nausea, vomiting, and impotence. It is a CYP substrate. It reduces loop diuretic activity, so if you're using those in addition to a loop, also be very, very careful with ACE inhibitors, which can lead to significant hyperkalemia. Baseline monitoring, so you do have to monitor start of these, so BP baseline and then 6 hours after the initial dose, and any dose changes, and that's related to significant hypotension after first dose. No renal issues, but do caution with Child-Pugh A and B for your hepatic impairment. Common reactions: non-severe hypotension, allergic reactions, CNS depression, neutropenia, and serious is severe hypotension, syncope, arrhythmia, and floppy iris syndrome. Arterial dilators, this is going to be hydralazine, minoxidil, dioxide, and sodium nitroprusside. They lower the BP by directly relaxing arterial smooth muscle, conserve sodium and water, and here is a mechanism of action with these. So it's directly acting on smooth muscle. So when do you consider using these agents? So these are definitely for your resistant hypertensive patients, but be cautious because they do have side effects that are consistent with some tachycardia and fluid retention. And often they need to be on loop diuretics to control hypervolemia. Minoxidil would cause hirsutism, so that may be problematic in women. These are very potent. They are reserved for resistant hypertension meds. When do we throw them on? When patients are on 4 meds and the blood pressure is still not controlled. So this is a new class. This is direct renin inhibitors, aliskiren or Tecturna. It lowers BP by decreasing plasma renin activity. So we know renin needs to turn angiotensin into Ang1 and then Ang2, so we are interfering with that conversion, and that would then create all of the down cascade behind it. When we're getting into the resistant hypertension categories, you guys should be referring to a hypertension specialist, either renal hypertension or cardiology. That is it for the blood pressure meds.